Hello, good morning again. I have the honor today of replacing Professor Laurent Pierot, who's still not feeling well. So I will try to give his presentation. He gave me his slides, yes, and so now you're looking at me, but you're listening to Laurent Pierot. The management of unruptured intracranial aneurysms. These are his disclosures, which are very similar to mine. So what is the risk of aneurysm rupture? Because if you have to manage unruptured aneurysm, you have to take into account two main things. One is the risk of the rupture, and the other one is the risk of the treatment. So we start with the risk of aneurysm rupture. We don't know, but there are some informations, and this is one of the most famous papers about unruptured aneurysm that came many years ago, 2003. And finally, they followed 1,600, 1,700 patients, and more or less what they saw that there was 0 ruptures for aneurysms below 7 millimeters. Here. Unless, of course, there were other things like position, posterior communicating, if there was another subarachnoid hemorrhage before. But as soon as you went to bigger, larger aneurysm, there was a higher probability of rupture. This study has been criticized a lot because this was not a randomized trial. It was just picking up patients, and these were the patients that were not operated upon. And so you have to ask why, and probably most of them were not operated because the surgeons thought that they had a low-risk aneurysm, whatever that means. Then other studies came, and this is from Japan, and they showed that, well, more or less the risk is around 1% per year, a little bit more for anterior communicating arteries. But remember, this is from Japan. And Japanese have different vessels than we do, whatever that means. And Uvela is a Finnish, very well-known researcher, and he more or less found a 1% per year, the same as the Japanese. Not too many patients, but followed up for a long, long time. And so at 10 years, the risk was about 10%, at 20 years, 23%, at 30 years, 30%. This was published in 2013, but this is a Finnish population. And Finnish have different vessels than we do, whatever that means. And in this population, of course, there was a higher risk for younger patients. Anterior communicating aneurysms are usually more risky than other locations. Smoking brings up the risk, but the size, as you see, is, again, the most important factor in deciding the risk of a rupture. But this is a subarachnoid hemorrhage due to the rupture of this aneurysm of anterior communicating. I think Pierot wanted to show this image for two reasons. One is the high risk of anterior communicating aneurysms, and the other is that when an aneurysm ruptures, it may be a very small aneurysm. So what about the size? We will come to that later. And this aneurysm was treated with a coiling. So we have seen the risk of natural history, or I should say, we have seen how much we don't know about the risk of natural history. Now let's try to see what is the risk of the treatment. And there have been studies about that. This is a French study that Laurent has conducted many years ago. And you can see that in small size aneurysm, the risk of complication is more or less the same than if the aneurysm is larger. What changes is the fact that in small aneurysm you have a higher risk of rupture because of the reason that you are very in a smaller space. And in bigger, larger aneurysm, you have a higher risk of thromboembolism because you put more coils, you stay more inside the vessels for all the reasons that we can cause thromboembolic complication. And this is even more obvious, even if it's not really significant, if you go to less than 3 millimeters and more than 3 millimeters. This is another Japanese study, and you can see more obvious this fact that ischemic problems just become larger and larger as the aneurysm becomes larger, and hemorrhagic problems tend to decrease with the size of the aneurysm. Pretty obvious, no problem. So the morbidity and mortality in this study was what you see here. And a meta-analysis in radiology of 2012 showed that unfavorable outcome was more or less 5.6% before the year 2000, but then it lowered after 2004. We became better, our materials became better, catheters were smaller, coils were softer, and were more practical. So we would really like to know and to put into comparison the rupture risk to the therapeutic risk. We should do a randomized trial. And somebody tried to do it. And there was this team trial that Jean Raymond in Canada decided to do many years ago, but it didn't work. It didn't work because nobody really recruited patients. Doctors don't want to randomize patients on unruptured aneurysms. But that's a big, big mistake because we will never know if we are doing good or bad. So more or less, we are left with common sense, and we tend to say that patient age, comorbidities, life expectancy, current medications, all these things, of course, have to be taken in consideration. All what you see here, previous subarachnoid hemorrhage, family history, if you smoke or you don't smoke, and if there are risk factors for treatment whatever that is. You have two options when you find an unruptured aneurysm. One is to not treat, and the other one is to treat. Probably in the mind of Laurent Pierot, it would be that no treatment, and you can follow up the patient in small aneurysms. What is small? How many millimeters? We have to decide. Older patient, how old? We have to decide. And of course, if you have increasing risk of endovascular treatment, like very difficult aneurysm to treat. And you do treatment for the opposite, of course, reasons. And he put this number here. So above 5 millimeter, he thinks there is an indication for treatment. If you don't treat, he says you have to follow up. And how? Probably magnetic resonance is the most used one. But CT angio gives you a better image of the aneurysm. So depending if you want to risk the radiation or not, or whatever, you may, or what's available to you, but you may use both of them. How often should you do it, this follow-up? Nobody knows. You could make a control 1 year after the initial imaging, and then you delay more and more, because obviously if nothing changes, like in this case that he produced, 2007 it's like this, 2008 it's the same, 1 year, then 2 years, and then 3 years, and then it's always the same. A few examples. This is a 55-year-old male with this middle cerebral artery bifurcation aneurysm. He has no risk factors. These are the sizes. Who would treat this aneurysm? Who would not treat this aneurysm? Okay, and everybody else is sleeping, of course. So he did not treat. This is another example, 29 years, male, same bifurcation aneurysm. Who would treat this aneurysm? Oh, no, because it's male. And he decided not to treat. Very small. And the bifurcation of the middle cerebral artery aneurysms are, we think, at lower risk of rupture than anterior communicating. This is probably intracavernous aneurysm, 5 millimeter. Who would treat? Oh, there are some of these. He decided for no treatment. Of course, these are the usual options of endovascular treatment. And these are the aneurysms that he did treat. So this is a 39-year-old male with smoker. And he put coils. Good result. 37-year-old female smoker, anterior communicating. And he decided to treat with a very good result, and probably that's a follow-up. 43-year-old female. These are all very small aneurysm. Middle cerebral artery. I don't know why he decided to treat this one and not the one before. 54 years old female. This was treated with stent and coil. Maybe the stent was placed because of a little loop of a coil who came out, and the follow-up is very nice. Another case, 59-year-old, small 7 millimeter aneurysm. This is anterior communicating, and he chose to treat it with a web. Nice result at the follow-up. Of course, they're all nice results. They wouldn't be here if they were bad results. So this is a 33-year-old female. I don't see the aneurysm. Ah, yes, here is the aneurysm. Another web. This is a spherical web. And occlusion. And this was probably a flow diverter, yes, case that I think produced a few ischemic hits in the follow-up, but probably they were asymptomatic. They found them at 3 months. And this is the just very more interesting aneurysm. I would treat this aneurysm, male, 51 years, and it was decided to put coils and to put a P48. This is a Phenox flow diverter. At the end of the procedure is very nice. A 6 months follow-up also especially is very nice. Another case with many aneurysm, multiple aneurysm, and he decided to treat all of them. This is 5 millimeter, 6 millimeter, 15 millimeter. All the coils all over the place, and everything is nice and good. Another case, okay, this is a VB junction aneurysm where he placed, I think it's a stent and coils. So all the cases. Conclusions. Indication for treatment of small aneurysms are established on a case-by-case basis, taking into account clinical factors, age, life expectancy, risk factors, anatomical factors, aneurysm size and location, lobulation. Multiple endovascular tools are available for the treatment of these aneurysms. But I would like now to tell you a few words. I cannot shut up on this topic. And so that was the view of Laurent Pierot, which is very much the official view all over the world. But I would like to make you a little bit think about this topic. So I give you some messages that I think are very important, and then you can decide. And this is very unofficial. It's me. And I start from the conclusions. And the conclusions that are that I believe that small incidental aneurysms are not a major threat for people's lives. There is a certain amount of uncertainty, but one of the secrets in life is to learn to live with uncertainty. So I don't treat small incidental aneurysms. No follow-ups, no screening, forget your aneurysm. But what is small? So my number is less than 8 millimeter. Certainly I would not treat. Yes, more than 10 millimeter. Is only size? Probably not. But we don't have proofs of that yet. So we don't have anything that tells us that anything else is important. No shape of the aneurysm, no hypertension, no smoking, no nothing. There is no proof that anything is worse than just size. So I think that's, anyway, a good start. First of all, I hope we all agree that aneurysms, for the most part, are not congenital. They are not genetically determined. They are just something that we acquire during our life. We don't have it before, and we have it after. After what? We don't know. So I see the aneurysm as a wound, a dissection in the arterial wall that appear as an accident at any time in adult life. And when it appears, it is painful. It's a dissection. That's when you have the sentinel headache, that headache that almost everybody will tell you they had before the subarachnoid hemorrhage. Then it starts growing to a certain size, and it's prone to rupture at that point. It's growing, it's unstable, it's a dissection, it's a wound, it's ready to rupture. But if it does not rupture, it will stop its growth, it will scar, it will heal, and will sleep for the rest of the life. And it will become an unruptured incidental aneurysm. So I think the trade-off between treatment and natural history is unfavorable. We saw that most people say it's 3%. I think in most hands it's more than 5%. It's more realistic. But anyway, this is a study on AJNR in 2011 by Andy Molyneux, and they looked at people who went to have a treatment for an unruptured aneurysm, and some of them did not go home. Why did they not go home? Because they had a problem. And how many of these did not go home after the treatment? 14% after surgical clipping and 5% after coiling. So that tells you more or less, it's very rough, but it's also very important. After the treatment of an unruptured aneurysm, 5% of the patients did not go home. Wherever they went, they were not as before. So what is the natural history? It's difficult to say because we don't have the data. First of all, how many people have an aneurysm? Of course, the better you look, the more you find. So the more we improve our instruments, we will find more and more. So it's not very nice to look at, 1998. We did not have angio-CT in 1998. We did not have MRI angio as good as now in 1998. But still, in 2006, if you look with a digital subtraction geography, you find it in 10% of patients. So in the literature, we have 1 to 10%, but I think at least 6 to 8%, but minimum, which means that 1 every 12, 15 people has an intracranial aneurysm. In a bus, there are 3 or 4. In an airplane, 20, 30. In a ferry boat, 120. In a football stadium, thousands. In a gym where they do all those kind of big efforts, there are 50 to 100 every day in every gym. Giving birth every day. Scuba diving every summer. Bungee jumping, but especially having sex any minute. So, I mean, you can do whatever you want with your unruptured aneurysm. It does not rupture. In Italy, we know, it's statistical data, that 8 over 100,000 people, the incidence of subarachnoid hemorrhage is 8 every 100,000 people. If we think that more or less 8% of people have an aneurysm, that means that every 100,000 people, you have 8,000 aneurysms. And that means that the risk of rupture is 1 per 1,000 per year. That's very simple epidemiological counting, nothing really fancy. And if the risk of rupture is 3%, it's a risk of rupture over 30 years. But if it's 5%, it's a risk of rupture over 50 years. So you take the risk that this person will have in the next 50 years. Do you really want to do that? Maybe I'm not right. Because one of the first objections is most of the aneurysms that cause a subarachnoid hemorrhage are small. So how can you say that small incidental aneurysms carry low risk? Everybody says that, and you have heard that yesterday or 2 days ago. So how is it possible? Well, one possibility is that the great majority of the aneurysms are small. So obviously, the majority of those that rarely rupture are small. But just because they are all small, I mean, the few that ruptures are small. Most car accidents are due to excessive speed. You would assume that you would have more accidents for the fastest cars. But no. We have many more accidents for slower cars. Why? Because of their prevalence. There are many more smaller cars than bigger cars, than faster cars. So it's not the fact that, there are, the cars that we see are small, so the small cars have higher risk of accidents. No. These are stereotypes. The common stereotypes is that Italians are related to drugs, but Russians with prostitution. Muslims with terrorism, French with alcoholism. There is no more French here, but Americans with wars. And incidental aneurysm with death. But it's a stereotype. We have not proven that. So if the aneurysms that we incidentally discover do not rupture, where are those that one day will rupture? Maybe they are different aneurysms. Maybe they are not yet there. So the possible scenario, as I told you, an aneurysm is born, you have pain. It's not rupture, it's just born. It's a dissection inside your head. It grows rapidly in hours or days and finally ruptures, and you have a subarachnoid hemorrhage. Or it does not rupture, and you have an incidental aneurysm. So the small incidental aneurysm is a scar. It is an aneurysm that did not rupture when it had a chance to rupture. Now it has healed. It will not rupture anymore, with exceptions, of course, in medicine. This idea, it's not really new. Already in 1987, this neurosurgeons, very skilled neurosurgeon, said the same things, that aneurysms develop over a relatively short time and either rupture or the walls undergo a process of compensatory hardening. So it's something we know from very far time ago. And even if you have a small aneurysm, you may have an intracranial bleeding for other causes. So there are some studies that have followed up unruptured aneurysm, and 2 patients over 93 had a subarachnoid hemorrhage. That's 2.2%. That's not nothing, but 1 is from an aneurysm that had already been clipped. 1 other from an aneurysm which was not there before. And 0 from the aneurysms that were followed up. So the aneurysm that you are following is not the one that will give the subarachnoid hemorrhage. And this was also the ISAT study that you now know very well. They followed up, for a minimum of 6 years and so on. And they had 24 rebleeds, 13 from the already treated aneurysm, so a re-rupture of the aneurysm that you were treated. 10 from another aneurysm, and from another aneurysm, 4, you already knew it was there, but 6 were aneurysms that were not there before. So if most of the ruptured aneurysms are de novo aneurysms, how functional can be our prevention? A hemorrhage in the follow-up may be due to the rupture of an aneurysm which was not there before. So the aneurysm treated today in the desire to prevent a future hemorrhage is not the one that will rupture in the future, because the latter is not even born yet. Let's take 1,000 people with an incidental aneurysm and treat them this year. Okay, we treat 1,000 people. They are all in this room. Next year, of course, there is 5% of complications, so we will have 50 people who have a serious morbidity or are dead. And we have 950 people who will have to be followed up with the usual things. We have to see doctors, and they are not very sure what will happen next year. So a certain amount of anxiety. And who may still have a bleeding from the same aneurysm or another aneurysm. Let's take the same 1,000 people and not treat them this year, and tell them that it's perfectly normal to have an aneurysm in the head. The risk of rupture is minimal, comparable to a car accident. They should not worry. They should just forget the aneurysm. Next year, we will have 2 persons who have a serious morbidity or are dead, the ones where the aneurysm ruptured. And we have 998, 999 people who will have returned to their normal life. And we will achieve parity with the other group in about 30 to 50 years. The amount of years that you need to reach the other number. But that is parity. At that point, 50 years, we will have the same number of bad outcomes. If you want to have a gain, you need to wait another 30 years. What a wonderful gain in anxiety, worries, family disturbance, personal expenses, healthcare system expenses. We spend a lot of money, or we earn a lot of money with aneurysm treatment. And then you can always think that in 20 years from now or in 10 years from now, you have a different treatment for aneurysm, which is much more cheap and much more effective, less complications. So why you take a risk now when thinking, oh, this person has to live 50 years, 50 years, but maybe in 5 years there will be a completely different approach to aneurysms. Of course, by not treating small incidental aneurysms, some people will not be happy, but I think they will not be the patients. So what should we tell the people who come with the small incidental aneurysm? Start by not saying you have a bomb in your head. Because most people who come to see me, they always say, oh, my doctor told me I have a bomb in my head. Of course, you changed the life of that person if you say that. He will never be happy again, whatever you do. What do I tell the people who come with a small incidental aneurysm? Having a small incidental aneurysm is normal. It's so frequent that it's normal. I cannot assure you that this aneurysm will never rupture. I tell you that the risk is very low. I think lower than the risk of treatment. Go home, live your life, and forget your aneurysms. We have tried, I go very fast here, to see if this reasoning is okay, because at a certain point I said, am I right, or am I doing something so incredibly stupid? So we phoned to the people who had come to my consultation. I said, go home and live your life. And we asked them, how are you? Trying not to be, of course, and these were all aneurysms below 10 millimeters, and they were all kind of aneurysms, shape, who cares, familiar, who cares, posterior anterior circulation, who cares. And the only common aspect was below 10 millimeters. And so I go fast just to tell you that 25% were between 7 and 10 millimeters. And we had 4 ruptures, which meant the risk of 1.9, almost 2 per 1,000 year person. So more or less 1 out of 600 every year. 3 anterior communicating. The interesting thing is this. We said, forget your aneurysm. But of course, many people did have follow-ups. Even the doctors told them to do a follow-up. 50% had a follow-up. And 98% had no significant change. So it really doesn't, it's not important. And remember, 2 aneurysms of the 4 that ruptured had a follow-up with no change. So why do I do a follow-up? It's not predicting the rupture. We said, don't treat. But some decided to treat anyway. How many of them? 46, which is 10%, chose to be treated. And 6 of the 46, which is 13%, had a complication for the treatment with an MRS of 3. So 13% had a complication for the treatment. It means that in our population, treatment had an outcome which was equivalent to almost 70 years of natural history. Is that what we want to have? So I believe our approach makes sense. There is probably no advantage in treatment. There is probably no advantage in follow-ups. If there is an advantage in terms of final outcome, it is so minimal that it probably represents a loss in terms of psychological and economical factors. So I finish with this comment, which is about efficacy. We know that usually the decision comes from the natural history versus the risk of treatment, but the treatment has to be efficient. If it's not efficient, it's not a treatment. Is our treatment efficient? Because we treat means giving care, but we should cure, which means eliminate the cause, the disease. We treat a lot, but do we cure? In modern medicine, we treat a lot, but we don't often cure. Okay, this we can skip. And then there is the burden of proof. In medicine, it should be obligatory to prove not only the safety, but also the efficacy of the treatment. If I give an antibiotic, I have to prove it's efficient. Otherwise, why do I give it? Are we sure that what we do on aneurysm lowers the occurrence of subarachnoid hemorrhage? Let's say I wake up tomorrow and affirm that if you give a patient 2 glasses of Coca-Cola, her aneurysm will not rupture. Why not? Ice in the morning, no ice in the evening, because otherwise... Would you believe me? Of course not. You would ask for proofs. And if I tell you that your aneurysm will not rupture if you pray the flying spaghetti monster, I hope you know the flying spaghetti monster. It's fantastic, Pastafarianism. If not, you go there. Every sunrise for 4 weeks and every sunset for 4 more weeks. Why not? It's a way of treating. Would you believe me? You probably would not believe me. Would you ask me for proofs? Of course you would ask me for proofs. So before talking about the risk of any treatment, what should prove that that specific treatment is useful? Not just a generic religious belief. And here we come to the Russell's teapot, which I hope most of you know, but anyway, I explain it to you. So Bertrand Russell in the early 20th century said that, well, well, I read it. Many Orthodox people speak as though it were the business of skeptics to disprove received dogmas, rather than of dogmatists to prove them. This is, of course, a mistake. If I were to suggest that between the Earth and Mars there is a China teapot revolving around the sun in an elliptical orbit, nobody would be able to disprove my assertion. Do you believe in the revolving teapot around between the Earth and Mars? Are you a teapotist? I mean, nobody believes it. We are all ateapotists. We do not believe in the flying teapot. But why? There could be. And so if somebody said, well, no, there is, how? Is it me that has to prove that there is not? Or is it he that has to prove that there is? Maybe we don't believe it because it is not in the sacred scriptures. Somebody said, there is, so now everybody believes. But the burden of proof lies upon a person making unfalsifiable claims, rather than shifting the burden of disproof to others. Prove to me that treating small incidental aneurysm is an advantage to people, then and only then I will accept it. Thank you very much. So, 2 quite different views on unruptured aneurysm, small incidental unruptured aneurysm.